Health outcomes. Changes due to interventions. To bring positive change, patient experiences and health must both improve. Healthcare costs must be lowered, and clinician and staff burnout has to end. But our problems are big. 133 million Americans have at least one chronic disease. 500,000 people are dying every year from hospital errors, injuries, and infection. The shortage of primary care professionals will be as much as 100,000 in just the next 5 years. Big problems require bigger solutions. Positive change needs acceleration. It needs to happen now. But these are not so easy solutions that many don't want to hear, and even few are willing to talk about. How to lead such a change? How to discover, discuss, and disrupt healthcare to make a difference now? This is VITALS, Visionary Health Leadership in Action.
Good afternoon and welcome to VITALS, Visionary Health Leadership in Action. The tools of VITALS are value, innovation, technology, advocacy, leadership, and service. These are the tools that today's transformative leaders are using to execute change in the healthcare system in the United States. VITALS is an open forum discussion for frank and meaningful dialogue with today's national healthcare leaders to hear how they use VITALS tools to implement change on behalf of patients and their community for the betterment of healthcare. Today, we are really lucky to be joined by Dr. Scott Knoer, the 13th Executive Vice President and Chief Executive Officer of the American Pharmacists Association. Dr. Knoer received his Bachelor's of Arts in Psychology from Creighton University and his pharmacy doctorate from the University of Nebraska. He completed a 2-year administrative residency and a concurrent master's degree in hospital pharmacy from the University of Kansas. Before his current leadership role at the American Pharmacists Association, he was the chief pharmacy officer at the Cleveland Clinic, where he led an international pharmacy enterprise with a $1.4 billion drug budget and over 1,500 FTEs in 18 hospitals across the globe in Ohio, Florida, Nevada, Toronto, London, and Abu Dhabi. Dr. Knoer is a passionate advocate for patients and the profession of pharmacy. He has successfully lobbied boards of pharmacy in Ohio and Minnesota to allow the advancement of pharmacy practice, and he has led initiatives that changed Ohio and federal law related to the elevation of pharmacy practice and reducing the impact on drug shortages. We are fortunate today to have Dr. Knoer. Please join me in welcoming Dr. Knoer. Sir, the floor is yours.
Thank you very much for that introduction. And I did the first thing right. I turned my mute off. You know, in the world of Zoom, I'm getting good at that. I'm going to be a little awkward for a second as I share my screen and bring up my presentation quick. So I'll make sure I share the right screen. And then I got to put this in presentation mode. Okay, can you just see my presentation without the notes section there? I think that's probably good.
Yes.
Well, it's great to be at least virtually back in Ohio. I know what really good world-class healthcare is from my time at Cleveland Clinic. And right now, you know, the luxurious life of a CEO, I'm at a Holiday Inn in Florida. I've been on a 2-week tour meeting with our frontline caregivers, pharmacists in hospitals, community pharmacists, chain pharmacists, College of Pharmacy, and hearing about the issues they are having. And I'm personally thanking them for fighting this COVID pandemic for the last 2 years. Now, I do have a relationship with Neomed. My son graduated last year from pharmacy school, and he's in Tampa doing a residency. So I've been up and down Miami, the Panhandle. Today I'm going to meet at Publix. Their headquarters is here. And then tomorrow I'm going to go to Tampa and go fishing with my son. So thanks for that introduction. And this slide is kind of significant here. Now, as many of the pharmacists in the audience know, APHA was founded 170 years ago in 1852. Our headquarters, the World Home of Pharmacy, is a national treasure. It's the only privately owned building on the National Mall. The original building, which you can see is the smaller sort of building up front, it was designed by John Russell Pope, the same architect that designed the Jefferson Memorial and the National Archives. In our marbled halls, we house the Robert Thom paintings commissioned by Parke Davis in the 1950s that display the 40 great moments in pharmacy. These paintings have been exhibited in the Smithsonian and at galleries around the world. Important to this audience that Thom also painted the history of medicine. This is one of those 40 Robert Thom paintings depicting the separation of pharmacy and medicine in 1240 AD. Pharmacy and medicine have officially been distinct disciplines for 782 years, when in 1240 AD, King Frederick II of Hohenstaufen issued an edict for the first time separating these professions and issuing professional regulations for both. It was recognized a long time ago that the complexity of each of these disciplines, pharmacy and medicine, necessitated a focused approach to each. Now, it shouldn't be surprising to anyone here that the healthcare industry is experiencing very, very challenging times. We had challenging times before we threw a pandemic on top of it. And I'm going to talk a little bit about these, but knowledge is expanding at a logarithmic pace. It's nearly impossible to keep up with everything in medicine or pharmacy, let alone to try to do it all without the help of interdisciplinary teams. As mentioned in the video, there's a significant primary care physician shortage. Our country is having a national reckoning over racial disparities in healthcare. And the issues I'm going to talk about here shortly only make those problems worse. We've clearly got a global pandemic. And I don't know about medicine, but we have seen decreasing enrollment in colleges of pharmacy for the last 5 years. Now, both of our professions and healthcare workers in general are experiencing burnout, approaching crisis levels. Now, while COVID has obviously bent our healthcare system near its breaking point, there are issues of falling professional fulfillment in both pharmacy and medicine before COVID. These are just some headline slides. Burnout among physicians, a pervasive problem that can lead to major medical errors, NBC News. Overworked, understaffed. Pharmacists say the industry is in crisis, putting patient safety at risk. And then a broader article, because our nursing peers are experiencing the same thing, the US faces crisis of burned out healthcare workers. Now, again, we'll talk, there were issues before COVID, but you can go on adrenaline for a few months. When we first got the vaccines in hospitals, people were pumped up. Your pharmacy students and medical students, I know the pharmacy students vaccinated patients. My son did while going to Neomed, and literally, kind of vaccinated our way, we thought, out of this. But you can't run on adrenaline for 2 years. Okay, so folks are just burned out, quitting in droves. Now, while I know a lot about interdisciplinary care from my days at the Cleveland Clinic, clearly my expertise is in pharmacy. Now, here are the realities on the ground. And I'm seeing that here as I go across various pharmacies in Florida and speak with our caregivers on the front lines firsthand. So the largest segment of pharmacy is still community pharmacy. When I say community pharmacy, that's both independents and chain pharmacies. It tends to be a little bit worse in chain pharmacies due to the volume. But community practice is challenging. Okay, our members report low well-being. Saying you have low well-being is the same thing as saying you have high burnout. And that's because of the high speed, high demand, high stress, and bad metrics. The pharmacists have to make so many callbacks and put some people on so many 90-day refills. It's leading to safety concerns, eroded standards of care, and burnout. I'm going to talk a little bit about some of the reasons that's happening in a moment. And pharmacies are closing, okay? And where are they closing? They're not closing where I lived in Medina, okay, when I was in Ohio. I now have a house in a nice area of Columbus, and they're not closing there. They're not closing in my apartment in Alexandria, Virginia. They're closing in inner cities, in communities of color, in rural areas and underserved areas, compounding the racial disparities in healthcare that we had before this. And why is that? This is one of the main problems. The financial incentives are completely wrong. If you said, how can we design financial incentives for pharmacy? The worst way for healthcare, you would probably design our model. And one of those problems is that pharmacy resources are being usurped by pharmacy benefit management companies that pull vital funding out of our practices, compromising access and the standard of care. I could go on all day about PBMs. I'm not going to do that. I will do a little bit though. And part of the problem, just to set this up, is there's been integration in the pharmacy and the medication world, which making it bad for physicians and for pharmacists. So there are only 3 major PBMs that have 80% of the market share. Community pharmacists cannot negotiate with PBMs on contract. It's take it or leave it. And if you leave it, you lose a third of your business. And we have the oligopolies are vertically integrated. Okay, so the insurance company owns the PBM and the pharmacies. And now for our medical folks here, what are they doing? They're buying physician practice as well, limiting competition and causing major problems. What's this do for our physicians? Okay, with this market share and they owning their own specialty pharmacies, they force patients and physicians to use their pharmacies. This creates stifling bureaucracy for our physicians with prior authorizations. You want to talk about wasted healthcare dollars, having to have staff just to do prior authorizations. Physicians need this extra staff to navigate the paperwork and denials. The patients suffer the most. This results in limited patient choice and limited provider choice on what you can prescribe. Ultimately, these cartels are putting pharmacies out of business and creating pharmacy deserts. As we've seen during COVID, pharmacies are public health infrastructure, important access points, demonstrated by the fact that the majority of COVID immunizations have been given at pharmacies. When the Cleveland Clinic and every other health system in Ohio and across the country stopped doing elective procedures, which they just did again at the Cleveland Clinic and in Ohio Health, pharmacies were the only place where patients could see a healthcare professional. So we're losing pharmacy access points. Is that okay? Are there plenty of other places where patients can get access? Is there a trend where there will be more healthcare providers in the future? Well, if there is, it's certainly not coming from the profession of medicine. As noted in the video before, we have a physician shortage that is only getting worse. The American Association of Medical Colleges, of which Neomed is a member, paints a very scary picture. They said that at a minimum, there would be 37,000 short by 2034, up to 124,000 physician shortage. I previously mentioned the closure of pharmacy. It's not just independents. So now that CVS Caremark, the big chains, they own the PBMs, they didn't pay pharmacies enough, the independent pharmacies closed, they bought their practices. Now they're consolidating and closing their least profitable pharmacies. They announced recently that CVS is closing 10% or 900 pharmacies across the country. Again, where are they closing them? Underserved areas. This slide talked about 60% of Indianapolis neighborhoods now are pharmacy deserts, where there's not a pharmacy within a reasonable area. We talk about the issues with population health, food deserts. We also have pharmacy deserts. So on top of the mounting challenges that I've just discussed, we're in an era of unprecedented medical advances. Okay, new to us are mRNA vaccines. However, maybe not to your researchers. You know, I'm talking to an audience where some folks in this audience, both on the pharmacy and medical side, probably know a lot more than I do. So I'm talking about high picture, big picture. But although they're new to us, because we just heard about it with Pfizer and Moderna, they've been in the pipeline for nearly 20 years. Now, manufacturing capacity has increased dramatically in the last 5 years, and especially in the last couple of years since COVID. since the government has thrown a tremendous amount of money at the infrastructure. So we're going to see more and more of this in vaccine advancement. So you clearly know about mRNA vaccines, unless you've been living under a rock for the last couple of years. But it's not just the vaccines that we see. In the pipeline, there are many more mRNA and viral vector vaccines. More for COVID-19, as we have variants, but also for Ebola, rabies, Zika virus, influenza, and CMV, to name a few. Another area of dramatic innovation that's hard to keep up with, right? Okay, physicians have a lot to do. We have to diagnose, we have to treat, and technology is expanding rapidly. New drugs are coming all the time. That is what pharmacists do. They study drugs, and that's our specialty. So we need to work together to help each other. But in cancer immunotherapy with lipid nanoparticle mRNA platforms, which stimulate immunotherapy toward cancer antigens. Again, you probably got people on this call that teach these lectures, cancer vaccines, oncolytic viruses, which wake up cold tumors. So while there's a lot of stuff in the pipeline, some of them that I'm going to mention here are unresectable melanoma, glioblastoma, and colorectal. So it's amazing the things that we're doing with this technology. Now, on a related note, with personalized medicine, there are thousands of clinical trials going on right now. Some of the approved agents, which have their own sets of issues, because when I was still at Cleveland Clinic, we had drugs for spinal muscular atrophy, which are ridiculously expensive. They were $600,000 first year, and I believe 200, 300 a year after that. Don't quote me on that's directionally accurate. So like, who gets it and who doesn't? But those are problems, but we're able to cure diseases we could not do before. I've listed some of them here for you to look at. Retinitis pigmentosa, refractory, B-cell lymphoma, a lot of the CAR T therapy, and you can read these slides yourself. But those are ones we can get today. Okay, those are ones that chief pharmacy officers are trying to figure out how to get the drugs and how to deal with the budgets and payers and all of that. But in the pipeline, okay, it's not just those super focused on small amounts of patients. Transfusion dependent beta thalassemia, big diseases, impact lots of people. Parkinson's, HIV, Alzheimer's, which I'm getting closer to every day as I get older here. Heart failure with reduced ejection fraction, and hemophilia, to name a few. So we're seeing a lot, but oh my God, a lot is coming down the pipe. So then there are gene silencing agents as well. So some of the approved agents, again, are those very expensive ones for targeted rare diseases, Duchenne muscular atrophy, spinal muscular atrophy. Then there are also approved RNA interference agents for the disease states listed here. And in the pipeline though, okay, rather than these just, again, these acute ones for just very small populations, in the pipeline, we've got RNA interference agents that are going to be game changers for glaucoma, hemophilia, LDL, reduction of LDL-C concentrations, and dry eye disease, things that impact many, many patients. Now, this isn't intended to be overwhelming. Okay, it's not intended to make you question your decision to go to pharmacy or medical school. In fact, just the opposite. Now, while we have our challenges, these are incredible, noble professions that are going to continue to advance at breakneck speed, which is both exciting and a little scary. So what? How is this all relevant to interdisciplinary care, to physicians and pharmacists for this audience working together, but also with the rest of the healthcare team? And how do we take back our professions and take collaboration to the next level to improve patient care and to to reclaim the joy in our careers, right? We got burnout, we have fewer folks going to school, we got all kinds of issues, we got PBMs, we got prior authorizations, we got electronic medical records, which are a blessing in some ways, but also, you're kind of slave to the electronic health record. So how do we work together? How do we work together to make it easier to take care of patients? We've been interconnected, autonomous partners for 782 years. So what is the next 35 years, which our students graduating will likely be practicing that long? What's the next 35 years of your professional career look like related to partnerships interdisciplinary care to help patients, to help each other. Well, a lot of that is happening in population health, and we were certainly seeing this at the clinic before I left. Although we've gotten our reputation from taking care of the sickest of the sick, we also tried to keep patients healthy. So I talked about the advances in gene technology and all that, but big data and AI impact every industry, okay? And we're doing more and more to leverage that to treat entire populations. I had the joy of going to a talk last week by Mark McClellan, the former head of the FDA, and Amy Abernathy, who worked at the FDA with him, who now runs a clinical trials company. And it was mind-boggling the amount of data that they're leveraging. And again, you have researchers there at Neomed, so they know more about this than me, but you're getting data from so many places. You're getting from the electronic health record, you're getting medical claims data, and personal device data from smartwatches and all. Now, there are issues with filtering that data and getting the good data, but this speeds our discovery, this speeds our ability to translate medicine faster to see if trials are working. It's only going to continue to increase. And also we have value-based payment systems, okay? So we are rewarded for improved quality as well. At the Cleveland Clinic, when I got there, we had 2 pharmacists embedded in our internal medicine clinics. I worked collaboratively with the head of internal medicine, and by the time I left, we had 35 pharmacists embedded in medicine and specialty clinics. And guess what? Every clinic we put a pharmacist in, their hemoglobin A1C was better. Their time to therapeutic for hypertension was better, both initially and 6 months later. So pharmacists and physicians working together can definitely improve outcomes in value-based payment models. But this necessitates partnerships and wraps. So how do we leverage the medicine and pharmacy partnership? These are the goals. These are my goals. First, it's about the patient, right? How do we comprehensively serve patients and society better? How do we reduce those racial disparities in healthcare? And for this group of students who's entering a 35-year career, how do we reestablish joy in our professions? They're enablers. There are things we can do together, okay, to help move this forward. The first is PBM reform. Ohio is the center of shining a spotlight on the dark underbelly of PBMs. When I was at Cleveland Clinic, we saw that in Ohio Medicaid, the PBMs, the money that your parents, maybe not you, but your parents and the faculty members gave to the PBMs for Medicaid in Ohio versus what they gave the pharmacists. The Ohio Pharmacists Association was seeing, members were saying, hey, my reimbursement's going down, what's up? So when you sign a PBM contract, you don't have a choice, you just sign it. And one of the things is there that you can't share that data. They say it's proprietary. So because it would technically be illegal, I can neither confirm nor deny that that study of 42 pharmacies in Ohio may or may not have included data from 19 Cleveland Clinic pharmacies. But what it showed is that 1 year in Medicaid alone, spread pricing, what the PBMs got paid versus what they gave the pharmacies, $244 million in one state alone. Since then, we've continued to slide a line on practices. I've talked about the issues for our medical staffs, the inefficiencies in the healthcare, the inability to get the drugs your patients need. So that is something together that we can work on. Another huge issue is that I said earlier, if we could design the most messed up system for pharmacy, we would design the one we got. First of all, 20 years ago, you could make enough money off dispensing a prescription where I could talk to your mom about her diabetes. Now, because PBMs have siphoned off all the money, the margins have shrunk so much that you have to go really, really fast and man the drive-through. The problem is pharmacists are not recognized as providers under the Social Security Act. We are not eligible providers. Social Security Act lists physicians, nurse practitioners, PAs, audiologists, nurse midwives, and others, so they can bill for their clinical services. Pharmacists are not listed. They cannot bill Medicare, the largest payer. Okay, so because of that, now Walgreens and CVS, the reason they do not have pharmacists spend time going over medications to patients is they don't get paid for it. If pharmacists were providers, They would be reimbursed by that for that by insurance, and we would incent pharmacies to do the right things. So advocacy is huge. And it's three parts. It's federal law, which we're trying to change, which, you know, if you read the papers, getting anything done in the federal government is difficult, but we're trying to get federal provider status. In Ohio, we got state Medicaid provider status. The Ohio Pharmacists Association, I got the Cleveland Clinic to support that. So we're providers, so we can bill Medicaid, and we're doing that in pharmacies and Ohio. And still, you also have to work with private insurers. We have to convince private insurers. And guess what? Every time we do that, when pharmacists are helping manage patients, overall medical costs go down. Okay, we have less foot amputations for diabetes, we have less stroke patients and hypertensive patients. So that team-based care, we need to be all practicing at the top of our license. Our physicians have to focus on the things that are important that only they can do. Our pharmacists need to focus on the things that they're the best at. And, you know, pharmacists, you know, talking about weight would not be the best thing to do, okay? Certainly we have some folks who have expertise there, but that's why we have dietitians, okay? When it comes to really managing medications, that's why we have pharmacists. However, you do not want me diagnosing the pus of any part of your body. So we need the right to work with the right, we need the right work with the right professional. Technology improves efficiency. I know electronic health records can seem like a major pain in the butt, but hopefully they'll get better. And with AI, we can identify the patients proactively that need interventions, the ones that will benefit the most from an intervention. And we need to extend providers. We need to increase access. We have a major problem with healthcare access in this country, and to reduce racial disparities in healthcare. So I have a question. Okay, we got pharmacists. Okay, we got physicians. We got pharmacy students, medical students. We have faculty from both sides. Do we, as professions on the national level, do we collaborate well? Do we support each other for the good of our patients? Well, here's some headlines. The PrEP Act allowed pharmacists in every state to vaccinate pediatric patients 3 to 18, regardless of state law. Doctors' offices were closed. Patients could not get vaccinated. And we're vaccinating the heck out of them, not just for COVID, but for other things. American Association of Pediatrics, or something like that, it's directionally accurate, I'm not Academy, maybe American Academy of Pediatrics, said the Health and Human Service Action on Pharmacy Vaccination is misguided. So the AMA, the largest medical group, opposed expanding access in a pandemic. Apparently, there are two schools of thought on whether it's a good idea in a pandemic to vaccinate children. I'm obviously on one side of that. They told me I was supposed to be, make people think. So now those are responsibilities. We need to work together for those things that help us all serve our patients. What are pharmacists' responsibilities? We need to do what I did at Cleveland Clinic, okay? We need to support our physicians relentlessly. The Cleveland Clinic had a very good model. It was a staff model. Our physicians were employed by the Cleveland Clinic. They weren't hunter killers. They didn't have to kill what they eat for billing. They were incented to take care of patients. So they were not turfy related things. They loved getting pharmacists. We created a refill center. Oh my God, doing refills is a terrible thing where pharmacists based. So we were able to partner. Everything I did supported our physicians and it supported our patients. So we need to continue to develop team-based partnerships wherever we can to increase access, to make it more enjoyable, right? Okay, if pharmacists, I got a group of pharmacists remotely doing refill authorizations, that makes physicians happy. And that group of pharmacists has access to the health record and can really do some really good things. Again, so restore joy to our professions, decrease racial disparities, and pharmacists need to educate our physician partners on the things we can do to take off their plate. Okay, our physicians are burned out. There's too much going on. There's too much for them to do. You only have 17 minutes, you're lucky, okay? I know that this talk is based on it and I'm probably talking over, but we need more time to spend with our patients. So collaborative practice agreements to manage chronic disease states, launch physician extending medication services to improve access. You know, again, we went from 2 to 25 embedded pharmacists and launched our physician refill center. I'm going to end with this slide, okay? This is an Ohio slide. Okay, this is NOTAM. at Zeke's Pharmacy in the Wright something neighborhood in Dayton, Ohio. It's a very underserved area. His pharmacy is a half block from one of the Wright brothers bicycle shops, so that's the right part of that. And it's incredibly underserved area. Because Ohio has Medicaid state provider status, pharmacists are being reimbursed to serve in this underserved area. I visited Knoer. I talked to his patients. Because his pharmacists are reimbursed by Medicaid as state providers, his patients' uncontrolled diabetes and hypertension improving. We know the model works. We need to end professional turf wars and embrace payment-related collaborative practice. The bottom line is if you don't get paid to do the right thing, you can't do the right thing for long without going out of business. Nope. So I think I might have just 1 second here. Yeah. So again, to sum that up, as far as whether we collaborate, very well. You know, I talked about the AMA opposing this. So turf wars are not helpful, and unfortunately, we have them. We have our issues where our disciplines are not collaborative between pharmacy and medicine. I can tell you definitively that pharmacy is not the source of that lack of collaboration. I happen to know the CEO of the American Pharmacists Association pretty well, and he's a huge advocate for professional collaboration. I encourage our physician colleagues to advocate with your professional organizations to maximize the healthcare team for access to our patients. Turf wars will not improve access. Turf wars will not lessen burnout for physicians or for pharmacists. Turf wars will not reduce racial healthcare disparities. They will not alleviate the provider shortage. They will not restore joy to our professions. So if you're an AMA member, turf wars make patients suffer. If you're an AAP member, kids suffer. Lean on your pharmacists to help solve these medication conundrums. Remain the diagnostic and care plan experts that our patients so desperately need as technology advances exponentially. Leverage your pharmacist's medication expertise to extend your reach. Okay, and now with that, I'm gonna try to turn off my slides and stop sharing my screen. And now, to get this discussion going, I'm going to introduce Betty Lynn Fisher, consumer columnist and medical reporter at the Akron Beacon General, who will be moderating the question and answer session. And Betty, I did warn you before that I tend to give really long answers to short questions, so I'm warning the whole audience.
No problem, no problem. Thanks for that really enlightening information, Scott. Wanted to say Happy New Year to everybody. And I am still sitting in here for Monica Robbins, the WKYC medical reporter who is recovering from her second brain tumor surgery. So we send out our positive thoughts to Monica in her recovery. And I also see that happy Pharmacist Day. It was apparently Pharmacist Day on Tuesday. So happy Pharmacist Day to everyone. There is a Q&A spot right there. If you have a burning question that you'd like Scott to answer, I've got a couple that I'm going to start with, but please go ahead and drop in your questions and we will try to get to as many as we can. So Scott, we're just going to jump in here. Donald is asking, do you think the boards of pharmacy need to get involved to deal with some of these serious workplace/workload issues pharmacists are struggling with?
Yeah, that's a great question. And so in my role, I know all the pharmacy CEOs. Al Carter I've only been in this job for just over a year and a half, and Al started right after I did. And Al is at the National Associated Board of Pharmacy, NABP. And they are, Ohio did a survey about burnout. Oklahoma created a form where pharmacists can report issues related to staffing. Boards of pharmacy are going to get inundated, and they used to sort of say, hey, we aren't into this, we're about safety. The role of the board is to protect the public health. Okay, well, if you looked at those burnout slides, both of them for physicians and pharmacists talked about the increased rates of errors, right? When you go really fast as a pharmacist, our pharmacists are reporting they're going home after working at CVS all day and saying, my God, I hope I didn't make a horrible error. So boards of pharmacy are under a lot of pressure to do more. And quite frankly, the folks on boards of pharmacy, they're good people, but they're saying, well, what can we do? And it's a conundrum Because if you say you have to have this many hours and then you don't have flexibility, and so it's really sort of challenging. Now, there are two good things. I warned you, Betty, I give long answers, short questions.
No problem.
There's two good things that have happened. One of them about a year ago, and this isn't solving world hunger. Okay, this isn't making peace in the Middle East. But Walgreens said, okay, we're going to close our pharmacies every day for a half hour so farmers can get lunch. Now, does that make it great to have a job? Not necessarily, but at least you can go to the bathroom and have lunch, because they couldn't do that before. Just about 3 weeks ago, Rite Aid said that they're going to have dedicated time. So if you're working at a busy chain pharmacy, you never get ahead, okay? Because you don't get paid after you shut the doors. So they're going to pay pharmacists either before or after the shift so that they can have dedicated time just to get caught up. And we are, it was about the boards of pharmacy, but APHA is getting a group of major chains together, because the chains don't like this either. They're having incredible turnover. They can't hire people. It's very expensive to have churn and to have upset employees. So we're having a little summit at headquarters Walgreens. Rite Aid, the CEO or the chief pharmacy officer Rite Aid reached out to me on LinkedIn and said, Scott, how can we help? So we're going to get together and try to help. But boards of pharmacy are under a lot of pressure. And quite frankly, they got a workforce development work group, and they're trying to figure out what they can do.
Speaking of that, this kind of dovetails nicely into another question. How is the American Pharmacists Association supporting the mental health needs of its members?
Yeah, absolutely. It's a major problem. All those slides, it's sort of a mental health crisis. So I've got all kinds of data. We've surveyed our pharmacists about where they are for well-being. And it's not just our busy chain pharmacists. So the danger zone for well-being, we had, it was 50.5% of chain pharmacists report higher burnout. However, overall, it was 33%, a third of the entire profession. And we have folks in academia here, and a lot of folks think, oh, the folks in academia don't have those same pressures. Well, there were 20% of pharmacists in academia report low well-being. So we're trying to do it through education and those things. Now, I tell you though, I'm get to the meat and potatoes of it. So the payment system is messed up. It's fundamentally flawed. Payment reform is the only way long-term to improve mental health. Okay, we can have apps where you can listen to music and you can think about your breathing. That's good. Okay, however, we have to solve it. The only way to solve it is to transform the payment mechanism and advocate. So we're advocating very hard. If chain pharmacies got paid to have pharmacists use their Pharm.D, they would do it. If PBMs didn't siphon all the money out of the process, we would do it. Community pharmacy used to be a place where you had good well-being, good mental health, okay? So what's happened? PBMs have happened, and the lack of provider status. So the biggest thing we're doing is addressing the core issues. We have all kinds of education. You can go to our website, and trying to help with mental health. But if we don't fix the issues, we're not really addressing the issue. And that's what I'm focused on more than anything else.
Okay. Moses asks, what are some initiatives at the national level to combat medicine shortages that we are currently experiencing with current supply chain challenges?
Yeah, medicine shortage, boy, that's another thing. The reason APHA recruited me was that I leveraged the voice of the national media better than most. And a lot of that was that a lot of the staff here, remember Toby Cosgrove, he's probably one of the best known CEOs in the last 20 years. Toby used to always call me right before he go on the news and say, hey, Scott, and then finally said, I'm too busy. He was on for everything. I remember one Sunday, he's on the Sunday news shows and he's talking about Ebola. I'm like, have we ever had an Ebola case at Cleveland Clinic? No, but it's Toby. So anyway, he started deferring to me on medication issues, and I started talking about drug shortages. Okay, and I started talking about egregious price increases. I don't know if you remember Pharma.D with Daraprim, where they shot the price up 5,000%. He's in prison now, and PBM issues. So with drug shortages, we got all kinds of problems which have been made worse by the supply chain. Now, I will tell you, the worst drug shortage issue we had is who knew that there were about 60 pharmaceutical manufacturing facilities on a hurricane-prone island when Puerto Rico got hit. That crushed us. I remember I had a reporter, I don't think it was from Akron Beacon Journal, but came to the Cleveland Clinic because it was one of the worst flu cases in a decade. And every patient gets an IV that comes in. and we couldn't get saline. All right, we almost ran out of saline. And the reporter asked me, Scott, are you worried about running out of saline or running out of products during this flu season? I remember my media training. The first thing they told me, don't incite panic. So I said, no, I think we'll be all right. Thinking, oh my God, we're going to run out of saline in the worst issue. So there's a lot of things related to transparency with the supply chain. Okay, we don't know where things are made. We don't have redundancy. Okay, we have products that are the vast majority, I don't remember what percent, it's at least high 80s and probably higher than that, of API, active pharmaceutical ingredient, is made in India and China. And we've got issues that have been highlighted by the supply chain. So there's been a lot with it, related to that. I just the same meeting where I saw Mark McClellan, we had a retired admiral that in the Trump administration, he put him in charge of getting ventilators and supply chain. So we're looking at bringing some manufacturing back, and transparency is a huge thing. We don't know where things are made, so when there are problems, we don't know how to fix them. Again, I apologize, a long answer to a short question.
No problem. I don't think it was me, but I did talk to a pharmacist about saline shortages. So I just Googled ourselves just to make sure it wasn't you and me talking.
All right.
It's entirely possible. I have a question from Dr. Langle. Turf wars are everywhere. CRNA versus CAA, CRNA versus anesthesiologist, psychiatrist versus psychologist, dentist versus dental assistant, internist versus nurse practitioner, etc. It is always over scope of practice and preventing one group from practicing in their space. It is sometimes based on what is best for the patient and more often protection of income. How should we approach this issue more broadly? Currently, the battle is usually won or lost based on who has the strongest lobby, not what is in the best interest of the patient.
That is a great question, and I 100% concur with that. Now, I'm trying to think if I've ever been turfy with anybody. I'm honest. I'm actually thinking, because pharmacists are not trying to stop nurse practitioners. Oh, you know what? There is one thing. We're not for physician prescribing. So yes, right? So not prescribing, clearly prescribing, but dispensing. There are issues with safety and double checks. So, okay, I'm being honest, right? I'm being honest. So yes, they're pervasive. And it is always about protection of income. But I'll tell you, realistically, that's not true, okay? I mean, more and more physicians are part of group practices or bought by places like Cleveland Clinic and Ohio Health. And then it's not there, again, it's sort of eat what you kill. It used to be the same thing for community pharmacies, community pharmacies were, the Ohio Pharmacists Association was primarily independent pharmacies. Well, it's not anymore because, we got pharmacists in chains, we got them in hospitals. It used to be independent physician practitioners. And sure, we've still got a lot of those, but more and more are getting grouped. So as we change, okay, the turf isn't there. Toby Cosgrove, who never hesitated to call me about anything. Hey, I'm looking at this company's stock. What do you know about it? Whatever. So I always answer Toby's call. He's a great guy, by the way. So I called Toby about a year ago. I said, Toby, would you sign on to this bill we've got for pharmacist provider status? So, we do need to look at the patient. I mean, it was an incredibly important question. And we have to look at realities of access, right? I mean, okay, if physicians want to take care of every patient, they can't. Okay, you can't. There aren't enough of you, and there aren't going to be enough in the future. So yes, supporting each other is absolutely critical. And I'm lobbying every day. I mean, that's what I do. I'm outgunned. I'm not gonna lie. The AMA has a butt ton of money compared to what the American Pharmacists. I got one lobbyist, Alicia Carey, and she's pretty good. She's outgunned. Okay, so we found out the last time we were this close to having a provider status bill for underserved areas. There's lots of underserved areas where pharmacists would be able to bill Medicare for certain things. And Buddy Carter is a pharmacist who's a congressperson. And, the AMA never officially said they weren't supported, that they were against it. They kind of went neutral on it. Buddy says, Scott, Alicia Carey, your lobbyist left, the AMA was here and said, we absolutely can't do it. It's terrible for patient care. So even if they don't have a formal statement, yes, it's they call it scope creep. But how to fix it, if you find out, give me a call. I'm trying to do what I did at Cleveland Clinic. Okay, at the Cleveland Clinic, oh my God, I supported our physicians. The physicians are the quarterback. They're the backbone of the healthcare system. and they're overwhelmed. I'm like, we can help, okay? We can help. So if there are ways that we can work together, that I can demonstrate that our pharmacists across the country can help, because I did it really well at the Cleveland Clinic, I'd like to try.
Okay. Next question is, with much of the narrative about COVID-19 being about testing and vaccinations, has the pandemic had a positive or negative impact on the reputation of pharmacists?
I will unequivocally positive. Now we're having problems right now because with Omicron, we can't get tests. Our pharmacists are so busy with boosters. And this is what I'm trying to leverage, okay? Pharmacy is public health infrastructure. Pharmacists always kind of operated, people, they knew their pharmacists. They didn't necessarily understand. We were the only place you get healthcare. The vast majority of immunizations were given in pharmacies. Pharmacists, just like, oh my God, all our front care workers, our physicians, our nurses are seen right now as the superheroes that they are. How they, I've been on this thank you tour in Florida for 2 weeks. 2 weeks is entirely too long to live out of a rental car, by the way, in case you're wondering. It's not real glamorous. So right now, yes, the time is now to try to get these things done. However, life's tough. People are fickle. If we get out of this pandemic, becomes an endemic and it's not critical anymore, it's what have you done for me lately? People are going to forget. I'm trying to thread the needle. We're trying to push this forward right now while people, because otherwise 900 pharmacies, CVS is closing. Again, not in my neighborhood, it's going to make things worse. If we don't fix the payment model, we won't be here for the next pandemic, okay? Who is going to immunize everyone when you can't leave when everyone else is closed? So yes, I think pharmacists are seen in a light they've never been seen before. I'm Rahm Emanuel, who for the students may not know, the faculty does. He was Obama's chief of staff and the mayor of Chicago. And one of the things he was famous for saying is never let a good disaster go to waste. And do things you never thought you could before. And that sounds like an opportunist. I coined the phrase in an article, benevolent opportunist. Okay, we want to do this for society. I'm not doing it to make Scott Knoer rich. I'm trying to move the needle while everyone's talking about it. And we got a couple legislative things we're in the middle of. Yes, pharmacists are being recognized. However, it's not helping them. They're burnt out and they're tired.
The next question actually might help with some of those top priorities. Richard asks, what are the top 3 initiatives that APHA will be working on in 2022?
Yeah, so I'm a simple man. I'm a truck driver's kid from Council Bluffs, Iowa, so I try to make things simple. Everything we're talking about, okay, there's a question about what are you doing for mental health, okay, racial disparities in healthcare. It all goes back to payment reform. Payment reform is the only way for us to solve. That includes scope of practice, okay? That's 3 parts. So what I'm doing, okay, is I'm trying to change federal law. 1, we have a pretty big bill to give pharmacists, make them providers under Medicare. So that's number 1. Quite honestly, our lead sponsors say it's not going anywhere. Okay, right now we got 8 million co-sponsors, but there's not the will to drive that. So what I've done, okay, and this is not public knowledge yet, we don't have a bill yet, I put together a coalition. I got Walgreens, CVS, Kroger, Amerisource, McKesson, Cardinal, us. Well, they all put in $500,000 each. And then we're a nonprofit. We put in 250, so did ASHP and NACDS, the National Association of Chain Drug Stores, and the National Association of Health System Pharmacists. What we're trying to do is make the PrEP Act permanent. Okay, right now it all expires. Okay, so vaccinating pediatric patients, okay, be able to test and treat for COVID. So we're trying to do Pharmacy Heroes Bill, call it whatever you want, that we would be able to, so that is a huge priority for me. I'm here today in Florida. I don't know if you're aware of it's a Florida chain, Publix. As soon as I'm done here, I'm going to Publix and I'm asking them for support for this to try to do that. So we're trying to get federal law, a bigger one. We're trying to get a focused law on the PrEP Act. It's like, guys, we're doing it, okay? We literally saved the world through vaccinations. Okay, it's a tough virus, it keeps coming back, but we vaccinated everyone. And then I'm also working with states. The American Pharmacists Association never used to focus on states. They just focused on federal issues. Guess what? I came from one of the best lobbying states in the country. Ohio is the gold standard for exposing PBM issues and for having state provider status. So when I came there, first person I called, a lot of the pharmacy people in the audience know Antonio Chacha at the Ohio Pharmacy Association. He's the one that started the data company that I gave my data to. So he's testified at almost every state legislature. I hired another Ohioan, there's almost no one except Ohioans in DC now for the American Pharmacists Association. I can say that in this audience, everyone else like, you only hire people from Ohio, and that's not true. But Michael Murphy, a past student president, he did a 2-year fellowship at Ohio State where he in advocacy. So it was great. He worked in a medicine clinic, saw patients, got his Medicaid provider status billing code, understands how to bill, and then he created educational programming, and he went to Knoer in Zeke's Pharmacy in Dayton, and he showed him how to bill, okay, and that's where, so federal law, okay, state law, PBM bills, we sued Health and Human Services saying you can't have DIR fees is another thing. It's complicated for medical staff. A lot of the pharmacists know. It used to be when you got paid, okay, you got paid. Now you get paid, and then they claw back money. They say, oh, you didn't meet quality and safety metrics that you can't impact in a pharmacy, and they take money. Sometimes the pharmacies are actually underwater. So we sued Health and Human Services saying you can't do that. They just, CMS just put out a draft statement saying all fees have to be at the point of sale. They can't be retroactive. So now there's a 60-day comment period, and you think AMA has lobbying power? Oh my God, the hundreds of billions of dollars that PBMs have. You know, it's certainly David versus Goliath. So, and then, so the top 3 things, they're all related to payment reform. It's payment for services, for clinical services, PBM, fighting PBMs, and then it's working with insurance companies. Because in Ohio, we got law passed, but Medicaid said it didn't create billing codes. We pressured them in the Columbus Dispatch. If you ever get a chance, Google Columbus Dispatch side effects series. That's where all of these stories about payment issues and Centene having to set aside $1.2 billion nationally, being Yoast in Ohio sued them. They settled for hundreds of millions of dollars because they've been stealing money from the Medicaid system. So top priorities, getting pharmacists paid for the right things, federal, state, fighting PBM shenanigans, and getting private insurers. I'm having a conference. I'm getting all the big payers to come to the World Home of Pharmacy and talk about, hey, you're paying them here, you're paying them there. How do we do that together? Again, a very long answer to a short question, Betty.
And when does that PrEP Act expire?
It's not set when they declare the pandemic over. Yeah. So unfortunately, probably never. I guess would be endemic. It would be good never for pharmacists' abilities, but yeah, there's no expiration date. But theoretically, once they say, okay, pandemic's over, then all those things that we're doing for patients, we can't do anymore.
Okay. We want to be respectful of everybody's time. Thank you for all the questions. I'm not sure we're going to get to all of them, but let me try to circle up and talk about the future here. So one person asked, how do you advise pharmacy trainees to become leaders promoting change in their professions?
Absolutely. Join your student organizations. There are multiple ones there. APHA has a student chapter. Go to Legislative Day. Okay, I know Neomed's great. Okay, you can't bus everyone down to pandemic. They used to bus everybody to Columbus. I tell you, having hundreds of people in white coats there. A thing about state legislature is that some of your parents, your aunt may know a legislator. Talk to them. Okay, talk to them. Get them to come to your pharmacy. Get them to come to Neomed. Make those relationships. So students can absolutely help us advocate. I happen to have, it's hard to get a residency. There's more students, like 2,000 more than white residents. I'm a huge fan of residencies. When at Cleveland Clinic, we had 11 residents. When I left, we had 65 pharmacy residents. When we got to APHA, we had 1 resident in professional organizational leadership. We got 6 now. So we extended our deadline, apply to the APHA executive residency, and we will teach you how to advocate.
Martin asks, how do we get high school and college students excited about going to pharmacy school again? We know pharmacy is a great profession with incredible potential, but we also know pharmacy school applications have been declining dramatically for the last 5 years.
That is a great question. And again, for the pharmacy folks, the American Association of Medical Colleges, you have your group. The American Association of Colleges of Pharmacy is our group. Lucinda Main is the CEO. Almost everybody knows her from the pharmacy side. And Lucinda said, and you've probably seen this, she said she had one student tell her that 4 different pharmacists had told her not going to pharmacy school. So until we fix that, right? And now there's lots of places, Cleveland Clinic, we have, PGY2 trained oncology specialists will have their jobs and all that. But, it's like chicken or the egg. And until we fix the fundamental problems that make community pharmacy not fun, it's going to be harder to get people there, right? And we also, I've been around long enough. I know supply and demand, it's like a sine wave. Okay, I'm doing the sine wave here. We had a horrible shortage in the 90s. What happened? Neomed is a relatively new school. We had, I don't know how many we have. We have 7 colleges of pharmacy. I'm glad you're there, by the way. 7 colleges of pharmacy in Ohio. We have, I'm down here in Florida, we have 7. I think we had 4 to start. And some of them have multiple campuses because people wanted to go to pharmacy school because there was a shortage, salaries went up. People were like, oh, let's open a pharmacy school, okay? We arguably had an oversupply, okay? When you have an oversupply, Walgreens, CVS wages stagnated. And we were seeing a decrease, and because they didn't make as much money, they cut staffing and all of that. So, right now, I was just at where I've been so many colleges of pharmacy. I was at Nova Southeastern College of Pharmacy 2 days ago, and one of the faculty is from New Jersey, and she showed me an email from CVS where they're giving bonuses. Right now, they're giving $50,000 sign-on bonuses again, like back in the 90s. But for certain areas in New Jersey. So we're seeing, because there's a shortage right now, we're seeing a temporary increase in salaries, but we got the burnout. So in order to get pharmacy students to want to go to pharmacy, we have to end the things that are causing burnout for us, just like physicians need to end the things that are causing burnout for them.
Let's do one more and then we'll send it back to Dr. Langell. Jake asks, do you think pharmacies like CVS implementing more health hubs into their stores is helping with the collaboration between pharmacists and other providers or causing more strain on the pharmacists?
I could see that both ways. Now, in that area, you're going to have a PA. Some of them, they're actually hiring physicians. And in that area, you're going to have the pharmacist there filling prescriptions. You're going to have and I'm sure the collaboration right in that spot is good. That's causing some interesting competition and potentially closing other access points. But sort of the jury's out, I think, in the microcosm of that store. But unfortunately, in the microcosm of that store, they're not having pharmacists as providers helping physicians. They're having them fill prescriptions. So until we can change that model, it's not going to be doing the things that all these students are going to school for right now.
Sounds good. Thanks so much, Scott. I'm going to send it back to Dr. Langell.
Thank you, Betty, for that expert moderation. As always, we are very pleased to have you joining us for each of these. Dr. Knoer, thank you for your passionate advocacy for the pharmacy profession and for the patients that we all serve. It was a wonderful presentation, and we learned a great deal from you.
Thank you.
I ask that you all join us next month when we'll be hearing from Dr. Ezekiel Emanuel, an oncologist and a bioethicist, as well as the Vice Provost for Global Initiatives at the University of Pennsylvania. Until then, stay engaged, stay active, be advocates for your profession, and most importantly, for your patients. And we look forward to seeing you again safely next month.
Health outcomes. Changes due to interventions. To bring positive change, patient experiences and health must both improve. Healthcare costs must be lowered, and clinician and staff burnout has to end. But our problems are big. 133 million Americans have at least one chronic disease. 500,000 people are dying every year from hospital errors, injuries, and infection. The shortage of primary care professionals will be as much as 100,000 in just the next 5 years. Big problems require bigger solutions. Positive change needs acceleration. It needs to happen now. But these are not so easy solutions that many don't want to hear, and even few are willing to talk about. How to lead such a change? How to discover, discuss, and disrupt healthcare to make a difference now? This is VITALS, Visionary Health Leadership in Action.